Now, look at that smile. Isn't it so bright and radiant? What if I told you that this smile is actually possible because of an implant retained complete denture? Don't believe me? Take a look. Yes, this patient underwent an entire procedure with implants, which the power of implants gave her not just the ability to chew again, but also it transformed her entire personality. So that's what implants can do. Gone are the days when a patient would come to you, accept a removable prosthesis, place it in the mouth in the morning, take it out at night, put it in a bowl of water, save it. And the difficulties that you had with removal prosthesis. The chewing forces were a lot lesser. There was abundant loss of bone. Residual ridge resorption was a huge challenge with these prostheses, even if it came to a fixed partial denture. Imagine cutting two sound good teeth to replace one missing tooth. Today, it would be considered criminal. I definitely consider it criminal to replace one tooth by cutting two good teeth, even if it means by a millimeter. Implants are here to stay. It became a paradigm shift about 50 years ago when Ingvar Brennemark first came up with the whole solution of implants accidentally while he was researching on rabbits. Those days, implants were placed by the surgeon in whatever bone that was available, and the flap was closed. The area was allowed to heal for about 6 months. Then the prosthodontist would go back in, place a healing collar, make an impression. It usually was quite a nightmare because the implant positions were spread out wherever bone was found. And these prosthodontists had to then come up with very, very innovative solutions sometimes. Sometimes the implants would be found between embrasure spaces. And to give them aesthetically looking beautiful restorations were always a channel. So often restorations ended up looking either like this, there was tremendous amount of bone that could be lost, or in some extreme cases, patients would even return with fracture of the implants because the prostheses were not balanced, the forces were not balanced on these prosthetics. The success criteria if implants were based generally on how mobile or not your implant was in the mouth, whether there was any radiographic evidence of any periapical radiolucencies, or in the year if the implant lost less than 0.2 millimeter of bone, we were very happy. So much so that if the patient didn't complain of pain, didn't complain of infection, we were all satisfied. Implant success was considered 85% after 5 years, maybe 80% after 10 years, and we were like, yes, our treatment is successful. But is it like that today? Today, patients don't come to us for an implant. They come to us to replace the missing teeth, to replace that missing function. And implants have become a lot more prosthodontically driven. Patients want that whatever they get replaced in their mouth don't scream for attention, rather blend into their mouth seamlessly and perform the function as well as their natural teeth did. So your implants need to fulfill or enhance the present health status of a patient. Because if a patient can chew well, he can digest his food a lot better. If a patient can chew well, his overall life expectancy can be improved. I'm not saying this, there are various studies that have said this. The patients want natural looking teeth, as aesthetic as possible. They have to be satisfied with what you provide them while fulfilling all the prosthodontic parameters of your implants being surrounded by at least 2 millimeter of healthy bone all around and a good soft tissue coverage, so much so that your prosthesis should blend in so beautifully, so wonderfully, and it should look like a wow. And that is how implants have become more aesthetically
It's
driven today.
7:45.
So, to help us with these procedures, we have 3D manufactured surgical guides. So, what are these guides? Like in life, we have mentors who guide us through our path, make our life easier, shorten our learning curves, and help us from falling in, getting into various pitfalls. These surgical guides are pre engineered, precision engineered tools designed usually on a computer and given to the doctor, help us drive these implants with a lot of accuracy and predictably in the patient's mouth. They help us to plan the whole therapy better. They enhance precision, as I've already mentioned. They simplify our surgical protocols. Overall, they enhance the patient's experience and use advanced technology so you're known more like a gizmo dentist. A little video demonstrates how we plan these guides. We make a CBCT of the patient, intraoral scan, and these two are then merged digitally in a software. Virtually, the implant is planned, and this planning helps us not just to understand where our implant will be located inside the bone, but whether the implant will need, the whole procedure will need to be flapped or whether it can be flapless, whether the patient will need some kind of bone graft. It gives you so much information that you can convey to the patient accurately that, hey, look, you're going to need a bone graft. You're going to need a flap raised. You're going to need all of these procedures because I can see this virtually. And once you're able to see this, you plan your process, you can plan your bills accordingly rather than getting surprises when you open up a flap as when you go in blindly. We plan this guide with IP. Not just that, we were even able to tell where the screw axis channel is going to be. We wanted it bang in the center, and that's what we got. So here you spend a little additional time planning, but the time on the chair is really saved. Needless to say, these surgeries become extremely precise, and thereby you can achieve long term success. Your functions like aesthetics, the patient satisfaction, functions, everything become a lot better. Ideal three-dimensional positioning of this implant is possible because of this surgical guide. This was a case where we extracted the front tooth because the patient had was undergoing some kind of internal resorption. We were able to place the implant in a three-dimensional position and give the patient a prosthesis on the same visit. All this was possible because we had planned it prior. Sometimes when we don't use guides to help us, we want our implants to be palatally positioned, especially in anterior teeth, so that the screw channel does not emerge out too facially. But look what happens. This becomes a blind procedure and ends up becoming too palatal. Or in this situation where the lingual cortex got perforated. So all of these potential problems can be simplified just by using surgical guides. Then after which it becomes a virtual no-brainer. Needless to say, it saves a huge amount of time. When a patient used to come to me earlier for a full mouth procedure, we'd spend the whole day sitting with the patient, opening up the flap, reflecting the flap, placing each implant, planning the position. It used to take a lot of time. Whereas now we've done all of this planning prior. You simply need to position the surgical guide in the patient's mouth. Go ahead with your osteotomies. No flap if you have adequate bone. No sutures. And you can even place the prosthesis in the mouth. The healing after this surgery is so much more faster. It's so less traumatic. And the patient comes back the next day saying, Doc, you've got magic in your hands. You really, I didn't feel pain, I didn't feel any swelling, and this brings you a lot more referrals too. So, how does this implant guide work? What are the steps that are needed for one to plan a surgery? You need a CBCT, you need to make an intraoral scan, give this data to your lab. In our case, we send it to image 3D conversion. They make a digital model, a digital wax up of the teeth that we're going to replace, and virtually position the implants in position. And then once you approve of the implant position with the whole planning, we get on a call normally with either by team viewer or any desk. And then once you approve of this positioning of this implant, where it's sitting, if you're happy with the way it goes, you give them the go ahead. They plan the emergence out for you. They will tell you if there is any sort of bone reduction needed. They will tell you if there's any sort of bone grafting needed, whether you need to reflect a flap or not. All of this is planned prior to the surgical process. They will design the guide in front of you and then give the print command. Your guide is printed either 3D by a 3D printer, or you can even mill it, so much so that you can even fabricate your prosthesis. They can send you all of this by courier. It reaches you and you take the patient in, anesthetize, position your guide, start your osteotomies one after the other, place your implants, and you're set. The various types of guides that can be made, they can be tooth supported based on the situation that you come across. They can either be tooth supported, supported by the teeth if the patient is completely dentulous and has just one or two teeth missing, or they can be tooth and tissue supported if there are multiple edentulous spaces, or they can be completely tissue supported. Now, these tissue supported guides can pose a small challenge. You need to be able to accurately position your guide with the help of fixation screws. These are fixation screws. You position it correctly inside the patient's mouth and then proceed with your osteotomies. The pilot drill goes in first and then your sequential twist drills. This is a bone reduction guide. Sometimes you need to reduce bone. You need to, if it's an immediate implant case or a case where you need to factor in adequate uh, height for your final prosthesis, you need to reduce about 4 to 5 millimeters of bone here. So, how do you measure it in your mouth? If you just mark it with a pen and go randomly, you can sometimes even either reduce less or you can reduce more. So these guides come in handy where you can accurately reduce just the amount of bone that you want, reflect a flap, place the guide, cut off how much bone is not needed. And nowadays we get these stackable options where you're initially given a model on which you stack the fixation pin guide over which your bone reduction guide appears. You can place that, reduce the amount of bone that you want, remove that, place the osteotomy guide, remove those, place the implant guides, and then finally the entire prosthesis is then placed over the implant, picked up over your temporary cylinders, and you can polish your prosthesis and replace them in the patient's mouth. The entire process becomes so seamless that within a couple of hours you send the patient back home with complete set of teeth. Yes, there are a few drawbacks. I wouldn't call them major drawbacks. There is a small learning curve. Like anything new, even when you started dentistry, obviously you didn't know what dentistry was about. So there was a learning curve to learn your various processes. Similarly, there is a small learning curve, especially when it comes to positioning the guide. You have to ensure that your implant guide is positioned very well and thoroughly in the mouth. The planning takes a little longer, but I'd much rather plan the implant guide over and the entire surgical procedure sitting on a desk and on a table rather than do it on my surgical table. Don't you agree? So these are some of the cases that we've performed, the full mouth guides that we made with I3DC. and these were shipped to us where we were able to do a flapless procedure almost immediately. Both the upper and the lower were placed simultaneously in the mouth. Patient came in like this and walked out with complete dentures. On the same session, another case where we did this after opening a flap. We knew prior that the flap needed to be opened, some amount of bone reduction would be needed. And once this was done, we were able to pick up the denture. The temporary cylinders were placed on the implants, the dentures being picked up here. This would then be finished and polished and placed in the patient's mouth. What you see here is after 3 months when we were able to give the final finished prosthesis to the patient after complete healing. So some of the misconceptions about guided surgery are, oh, it may compromise safety. How? It can only improve safety. It can avoid those accidents where you can place the implants in wrong positions, you can hit a nerve, you can because you planned everything to the T beforehand. Guided surgeries, no matter what the kind of complex anatomies, we've been able to make guides fit accurately in the patient's mouth. There was a small learning curve. We've overcome that learning curve, and we find that more than actual surgical procedures without guides, guided surgical procedures are so much more simpler and easy. And patient comfort. Patient is a lot more comfortable with the guided surgery experience. There's absolutely no swelling many times, no pain. Patient comes back. I've got 101 testimonials saying absolutely no pain. My pain reduced. I've taken just one simple painkiller. So, yes, guided surgeries are here to stay. It is a paradigm shift in how we perform our implant dentistry, reduce the invasiveness, enhance the accuracy, the morbidity rate is a lot lower, the outcomes of these surgeries are a lot more successful. We have many, many studies that prove that the success of these surgeries are almost 98%. And that is a big number. So, with this, I'd like to say that if you've not tried out these guide surgeries, you must try these out. This was just a basic overview of how guided surgery functions. Our future webinars are going to tell you each of these aspects in a lot more detail. So, stay tuned, come back to us. Thank you for your patient listening.